Morning, everyone. Thank you all so much for joining us for our Fall Digital Health Summit. We're really excited to continue doing our roundtable format. We have a lot of really great discussions and speakers lined up for today. Just a few housekeeping things. There is coffee and drinks over in the side room, as well as restrooms right outside this room as well. And throughout the tables there are little microphones, these like little black box things. In the interest of accessibility for those who are joining us virtually, we'd ask that you please try to use one of the microphones if you are speaking, so that folks who are in virtually can participate fully and equally as well. You don't have to like pick them up or anything. You can just set it down on the table and it should be able to pick you up fine. Do you want to get started with just go around and introduce everyone? So you have a few minutes. Sure. So I can start. I'm Lydia. I'm policy analyst with CTeL. Many of you probably already know me, but it's great to see everyone.
Let's go this way. Hey, everyone. Welcome. My name is Jacob Harper. I'm a partner with Morgan Lewis. This is our office, so it's very nice to welcome all of you, as well as those of you who are on virtually. I'm really excited to help lead this conversation today. CTeL has been an amazing organization for 30 years? Is this the 30-year anniversary? I think so. Yeah, 30 years now in telehealth and digital health policy. So, it's really great that we've been able to keep the momentum going for so long. And it feels like these days, it's even more important than when we started out, because there's so many more issues, and it feels like we're closer and closer to getting to a place where telehealth and other digital health technologies are really starting to influence how healthcare is being provided. It's helped to bridge gaps. It's helped to make care more affordable, accessible, and frankly better. So really excited to be a part of the organization and looking forward to today. Christa?
Yeah. Hey, everyone. Thanks so much for joining us. As Lydia said, we are going to transition more to quarterly roundtable types of discussions. And as you saw from the back of the agenda, we are going to host a gala and a large digital tech showcase in the fall. It's going to be something that we haven't done before, but it'll be really neat and fun. And if you have never had the opportunity to kind of formally celebrate all of the successes that digital health has made, we're going to offer that opportunity. And you get to wear tuxes and gowns, and it'll be a lot of fun. Yes. So today was designed to be small because the conversations are really niche. We have people that are joining us over Zoom, but the goal of this is to be very collaborative in nature. So my name's Christa, and I've been with CTeL for 18 years.
Penny Kite. I am with Ballad Health, which is a healthcare system in the Appalachian Mountains of Tennessee and Southwest Virginia. They cover a 29 county area across both states. And I was telling Christa earlier, we're unique because we're two health systems that merged together. And we are governed by both the state of Tennessee and the Commonwealth of Virginia through a COPA, CA. I am the digital care strategy officer for Ballad, so I'm responsible for all things telemedicine. And I think the one thing that we uniquely use telemedicine on is we have over 500 nursing vacancies and over 300 provider vacancies. So we try to use telemedicine in order to bridge the gap on specialty care, and have really improved things with doing that.
Hi, everybody. I'm Syra Hawk, and I lead the Advanced Medical Solutions Group at Pfizer, which is a group comprised of half informaticists and half applied researchers. I've been coming to CTeL for, I don't know, maybe 10 years. I can't really remember. pre-COVID is like a blur, so I'm not actually sure, but something like that since before COVID. And one thing that I've been focusing on a lot is the intersection between policy, research, and practice. And that's one thing that I'm looking forward to talking a little bit more about today. And it's nice to see you all.
Thank you. Blake Halliday, Nightingale Education Group. I am our Director of Regulatory and Legislative Strategy. We are the largest fully online nursing education provider in the country. So been with CTeL for only about 2 years, year and a half, 2 years, and it's been a fantastic ride.
Hi, everyone. I'm Michelle Hager. I'm the managing partner of Blue Cirrus Consulting. This is actually our sweet 16 years in business. Yes. We specialize in the telehealth space, but management consulting across the country, doing work for health systems and for-profit and startups, companies across the country, helping them put it in implementation of telehealth and also understanding policy and all the other intricacies around telehealth.
Hi, everyone. Good morning. My name is Sophie. I am CTeL's newest employee. I've been here for about a week. I'm learning a great deal. I'm CTeL's new Director of Membership and Operations, and I'm also an attorney and will be doing some policy research. Now I'm going to do an awkward walk all the way around the table.
I'm Kellen Kreger, Director of Telemedicine for Wellnigh Urgent Care, one of the largest urgent cares in the United States. We do direct patient care to patients with traditional telemedicine and through telecard technology in our urgent care clinics.
Micah Matthews, Deputy Executive Director for the Washington State Medical Commission. We've been involved in the telehealth space since probably 2014, doing guidelines and policies. And I think we've been involved with CTeL since 2016, and you're going to hear a theme here.
Hi, I'm Taylor Bacharach-Nixon. I'm a management analyst with the Medical Commission. I mostly do communications and legislative work, and it's my second year at CTeL. This is our new policy director, Kajita Kita, and she's also very new. And so here's.
Thank you. Like she mentioned, I'm very new. So this is my first time in CTeL. So my name is Khadija Takeda, and nice to meet you all.
Hi, my name is Elizabeth Fitzgerald. It's also my first time at CTeL. I work with Hancock, Daniel, and Johnson, and started there in their hospital operations division in September, moving over from the government. Thank you.
Hi, I'm Leslie Ann Durant. I am the Chief Privacy Officer, Privacy and Data Counsel for Privia Health, also soon to be head of AI governance as we're establishing that program. So this is actually my my second visit here to CTeL. Privia has been, I think, involved for much longer, but we're based out of Arlington, Virginia, but we have medical groups in 15 states. So we are having fun navigating all of the various state requirements as it relates to virtual health as well as AI.
Hi, I'm Trina DePaul. I work at CTeL Health. We are a women's telehealth platform, and we launched our product in July with the first at-home cervical cancer screening that's FDA approved. So I think we've been part of CTeL a year or two. We're rather new. We're still navigating the landscape of telehealth, but happy to be here.
Hey, everybody. My name is Taylor Daly. I'm an Associate General Counsel at Waystar, which does everything healthcare payment processing. I support a team that works on clinical documentation integrity. We've got a heavily AI-enabled product, and I negotiate a lot with providers and work with their various AI committees to help give them comfort that we're going to treat their data well, protect it, and then use it to help patients and make sure that health systems can get paid.
Good morning, everybody. I'm Nora Cox. I'm the CEO of the Texas eHealth Alliance. We are a digital health trade association based in Texas, which means I am the thing that stands between all of you and the existential darkness of the Texas legislature on any given day. I have been a CTeL member for a long time, certainly pre-pandemic. My organization is 16 years old, but I worked on my first piece of telemedicine legislation in 1995 when I was 12. So
Good morning. Good morning. I'm Joe McMenamin. I'm a physician attorney. I practice law with Christian and Barton in Richmond, Virginia, and focus on the law of artificial intelligence in healthcare and digital health. And recently, I've been involved with defending a spate of claims in front of various health regulatory boards, physician boards, nursing boards, et cetera, some of which involve telehealth. It's been interesting work.
Hi, my name is Avas Bajwa. I'm a founder of a startup company. We are working in artificial intelligence and intersection of telehealth, retinal disease diagnostics. And one of my interests is in policy work that I'm very interested in working and reducing the cost of FDA for medical devices. One of the research, I'm actually looking for some feedback also. And in January, I'll be publishing some of the work. And I would love to collaborate with people here. I'm coming from Atlanta, by the way. Christa invited me, so I joined here to meet all of you. One of the other area is assistive artificial intelligence, retinal disease diagnostics. We are expanding in multiple states. I'm working with insurance companies in Atlanta. And actually, we are now registered in 34 states. So very excited to be here, learn from all of you and contribute. Thank you.
And I did get 2 eye exams in the past 2 years. The first year I had, what was it? Retinopathy, diabetic retinopathy. And last year, with AI's help, I did not have diabetic retinopathy. So congratulations, we're developing.
That's a very important point. Just want to add one thing. Just one very funny thing Jacob said, but actually this is one of my research area where when we go to federal agencies, we should not lock the algorithm. It should be continuous learning. Like doctors learn, AI should learn. So this is one of my research area. That's a very good point, by the way, Jack.
I try, thank you. So I think now, why don't we turn it over to the first panel? And as Lydia said,
some virtual folks.
Okay. Do we want to? Sure. Okay.
And we have some folks joining virtually, and want to give them a chance to introduce themselves as well. I guess we can go alphabetically, starting with Ali.
Yes, thank you so much. I'm glad to be here. Ali Alamin, the program lead at Children National Medical Center. I'm representing Teja Raichur, our director of telemedicine. Glad to be here and looking forward to hear about the interesting programs and the lawmakers here. Thank you.
Thank you. David? Carol?
Good morning. I'm struggling to unmute myself and make sure I don't go on camera since it's very early in California. Carol Yarbrough, UCSF Health. I've been involved with CTeL probably for 9 years now, and love to tell that Christa and I met on the internet. So that's how I got involved with CTeL, and very pleased to be here. Thank you for offering virtual.
Thank you for joining. I see David.
Dave Auburn. The new name of the company is Global Telefingerprint, and we share the medical multi-state licensing space with our Marshall Smith of the Interstate Medical Licensure Compact, and we are now specializing in privacy compliance. So we'll be contacting most of the folks one way or another, finding that there are, for any individual physician who's going to be getting licensed, there are 4, count them, 4 separate, simultaneously applicable privacy enforcement jurisdictions that apply to that one individual person all the time. So it's fun pleasing all of them. And the Privacy Association, 85,000 members strong internationally, says that at any given moment, 40% of all these enforcement agencies have their definition of consent undetermined. So 40% of them don't know how to comply, but you better do it.
Great. Jessica?
Morning, everybody. Jess Easterday from Amplify Health, located in La Crosse, Wisconsin. I'm the Director of Virtual Care.
Jordana?
Good morning, everyone. I'm Jordana Bernard, and I'm the Executive Director of Standards and Policy with Savado. We're a startup company based in Santa Barbara, and we're focused on developing a platform that will enable remote robotic surgery. This is not yet being done here in the US, but we expect FDA approval next year. It's being done around the world, and we're starting to think about all the policy and reimbursement issues for this new digital health model. And so I'm excited to be here today. Been with CTeL for many years, and I'm based in Florida. Thanks for the virtual option too.
And Mark?
Good morning, team. I'm Mark Noble. I'm the CEO at VitalNet. We're a healthcare work and data flow solutions company that's been focused on virtual care and telehealth for the past 35 years, and currently spending a lot of time working with states on rural health transformation and building out infrastructure to get expertise out into rural communities where the expertise doesn't exist. I plan to be with you all in person today. I had a procedure last Friday that has taken longer to recover from than I expected to. So I appreciate the grace in allowing the virtual opportunity here.
And then finally, Zuhal?
Good morning, Zawal Haidari. I am the Director of Digital Health at American Psychiatric Association. I think our membership precedes me, but I've been with CTeL for about 2 years.
Excellent. Excellent. Well, welcome everyone. It's so great to have you here either virtually or in person. So let's kick off the show with our first panel. Lydia and I are going to be presenting a little bit about what's happening in Congress right now. I think we use the words chaos, and I think that's probably a fair way to describe it. Say no more. So now we have an hour and a half networking break. No, I'm just kidding. But as Lydia mentioned, this is intended to be a very informal kind of discussion. So if there are questions, if there are comments, thoughts, please don't hesitate to jump in and just activate, what do we call it, the little black microphone thingy. Activate your little black microphone thingy right there, and feel free to chime in. So, but just a couple of sort of quick initial thoughts, right? As you know, to sort of tie it back a little bit, right? Congress right now, and for the past several years, has been in a state of, I think, chaos is a fair word, regarding how they are going to manage various kinds of digital health technologies, right? It's no surprise there. Telehealth being sort of Medicare coverage of telehealth, more specifically being sort of the big elephant in the room historically, and something that feels like it should have been solved 5 years ago, still has not been solved. CTeL has done a tremendous amount of work trying to advocate for additional education to help organizations like the Congressional Budget Office, see things a little bit differently, understand what the real life dynamics are when it comes to the ROI on things like telehealth and RPM. Unfortunately, they're not there. Fraud and abuse concerns have prevented Congress from being able to jump in, even if it costs more, and say we're sort of, fully into telehealth, even though when you talk to any member of Congress, right? I mean, virtually every single one, they'll say, yeah, I support telehealth for my district. I support telehealth for my state. They want it. They need it. They know it's there, but we just don't have the political capital at the moment to pay for it in a permanent kind of way, right? So it's a thing I think that people are always interested in. I don't think, just sitting here, that it will ever be something that's ever goes away at this point. I think that the toothpaste is out of the tube, but unfortunately, there's also not the thrust that we have to be able to make it into just a permanent, let's change Social Security Act 1834M so that, it actually allows Medicare telehealth coverage in the way that we've experienced it during the pandemic. So it is certainly frustrating. I think it stifles innovation and investment in this area. It prevents providers from really embracing this as another tool in their tool belt. And we saw that during the shutdown, right? So we just had the biggest shutdown in U.S. history. Is that correct? It was the biggest? Yeah. Longest shutdown in U.S. history. And this one was very impactful for people who provide telehealth services, right? I'm sure a lot of the folks in this room have in their organizations had to probably shut down every telehealth service, reschedule patients, switch telehealth visits to in-person visits, and it caused a tremendous amount of administrative burden, of probably missed visits, missed revenue opportunities, et cetera. And unfortunately, the news that I hear, Christa told me this morning, because of this, but it's likely just to happen again, right? When the shutdown was finally resolved after 35 days or so, they pushed it back. The budget is now pushed back to January 30th. So we now have, by my calculations, about 45 more days until we go into another shutdown. Have the issues changed? I don't think so. Have the parties changed? I don't think so. So in terms of whether there's the likelihood of another shutdown happening, I think it's extremely, extremely high. And there's always going to be that telehealth component, at least for the near future, in any continuing appropriations vehicle that we have. And so I think that's just sort of one of the issues that we're going to have to deal with, is this back and forth of whenever the government shuts down or we get to September 30th or near September 30th every year, we're going to have to be prepared to shut down telehealth services for 2 or 3 weeks, or maybe just keep providing them and hope that they retro them, which they did this time, but that was not solved until the beginning of November, if we knew that was actually going to happen or not. So it really does create a situation that's untenable for telehealth providers and for larger organizations where telehealth is an important component to that. Lydia, do you have other thoughts on sort of telehealth generally?
Sure. I think one thing that I've always wanted to make sure we focus, especially for this summit, is understanding what we all can take back to our organizations, and really make this summit and conference ways that we can learn how to, better do all of our work. And I think one of the big takeaways from here is, again, that nothing is guaranteed until it is. There were a lot of people in the lead up to the shutdown saying that telehealth wouldn't go away, that it wouldn't happen, that there would be a deal, and that there would be nothing to worry about. This had happened in previous cliffs that we've seen as well. And we had usually been on the more cautious side in that. I know this is something that Christa and I have always talked about, how a lot of other organizations tried to minimize the threat of this. And I think the fact that it did happen for over a month demonstrates that until we have something that is more permanent and durable, that we can't rely on Congress's general desires for something. And I think it ultimately underscores the importance of contingency planning, and making sure that we understand that until we actually have solutions for this, we cannot act as if it's going to be guaranteed.
And I'm wondering, actually, do people have any experiences with I know obviously all the claims were retroactively paid, but does anyone have any experience or sort of war stories related to not getting paid for a month and a half? Did that impact your operations or anything like that? Do you want to share kind of just, it would be helpul, I think, for everyone to hear kind of what the impact was in the short term, because obviously we did get paid here, which was okay, but it probably was very no, I think you should be able to talk. Yeah.
All right. So we're 75% Medicare, Medicaid. So the first thing we had to do was put a disclaimer, and I think it's called a UBN. I'm not a billing person, but we had to put something in front of it to basically let that payer know. Basically let that payer know that, I mean, the patient know that there's a possibility we're not going to get reimbursed. And if we don't get reimbursed, then we're going to send the bill to them to get paid, which basically increased our cancelizations and pushed a lot of face to face. My concern is that it looked like our health system was doing it when it really was from the federal government. And we tried to explain that as well as possible. It really confused a lot of patients that for the last 2 years, they've been able to use tele for everything. And if you all know the area that I'm talking about, it's very mountainous. So it's 2.5 hours sometimes to get to the closest specialist. So that's a very long drive for teleneurology or for something like that. So we got a lot of feedback, and to be honest, and I think Lydia said it, even our health system was like, oh, they'll retro. It was only my team that pushed to have something proactive in place in case it didn't. So even health systems still have a glass half full about whether or not it's going to get, be retroactive, which kind of concerned me because we're about, and it's not a lot, but when you don't have a big margin, we're about 2%. Telemedicine is about 2 to 3% of their revenue. We only run a 1% over. So.
Oh, Michelle.
Do you want this one? Yeah. So one of my clients was considering selling and might actually still sell. And the reason why is because they're providing telehealth services. This is a for-profit entity, small, providing telehealth services into nursing homes, geriatric services, and specialty services into those nursing homes. Their margins are very thin. Their revenue is not the size of a health system. So even if their margins are low, the numbers are smaller. And having to float 45 days with the potential for another 45 days of payment to physicians and the outgo with, yes, we're going to get paid, but the amount of just debt that they were going to experience, they just felt like it wasn't going to be worth it. The stress of that on their business was going to be too much. And so, my role in that process now is referring them to someone who can help them sell their business. So what will they ultimately do? I don't know, but they were in a lot of stress and strain during this process. I just wanted to touch on something that you said earlier. One thing I've observed and that organizations that we work with have noted is that there's confusion with patients and with the general public around what's an institutional policy and what is a federal policy. And that is even before the shutdown, just with telehealth generally. There's a lot of confusion about, well, is this your policy or is this actually a law? Why can't we have what we want? And I think that's always there, but it was heightened in the shutdown. So that's something for us all to consider, because when we go back to Congress and think about, well, maybe their constituents aren't putting pressure because they don't understand what the problem actually is. So that's just something I wanted to note. Yeah.
Not where you are. Yeah. Joe, go ahead.
I'd offer a question that's sort of a variant on Jake's original question. And just anecdotally around the table, especially for those of you from health systems, I'm curious whether there's any evidence that the shutdown and its consequences for the availability of telehealth services had clinical consequences of any magnitude. I'm also wondering whether, assuming there's some indication that's the case, and I don't know that, I'm just guessing it seems logical that there would be, whether that's a topic that could be studied in a more systematic fashion, partly just to learn something, but partly perhaps to provide a little bit of a stimulus to our friends on Capitol Hill, who may or may not be conscious that the shenanigans that seem to occur more often than not nowadays have real world consequences for their constituents. Perhaps, and this is all speculation, perhaps if that were the case, they might exert themselves to achieve some measure of budgetary sanity and not do this brinksmanship that seems to be the MO of members of Congress at the present time.
That's a great question. Any comments? Yeah, try that. Yeah.
Let's see if it works. It works. All right. Hi, I'm Kelly Horton from the Academy of Nutrition and Dietetics, and we had a lot of stress among our membership and our profession. People know if they took those appointments, they were risking not getting reimbursed. So we put out information, let them know. I'm sure there are people who maybe they didn't reschedule their appointments, and so they are suffering and not getting the care that they need. But that's just anecdotal.
So do I have this right? I have it upside down. Sorry. We did see that during COVID, though. I mean, I think the shutdown time was so short this time, we would have to go back and pull the data. But during the COVID years, we did see a lot of people put off services. And in our area, especially, you know, that stage 1 of certain kind of, you know, whatever, cancer or whatever, where they weren't coming in. And it has now progressed to stage 3 or stage 4 because they put it off so long. The same thing with tele. The other thing I will say, and I think I've shared this with Christa, but the last time we were at DC and met with Congress, at least my Virginia and Tennessee ones, one thing I'm trying to get them to understand is talking about the CBO report. And again, I don't know government stuff that well, but when you look at teleneurology, for example, being proactive and being able to give a patient a teleneurology visit, especially on that ER inpatient side, reduces the time for disability. So even though you're paying for that on telemedicine, and there is national research out there because my data team has pulled it, a person 55 or older that would end up with a stroke has a 50% chance of ever going back to work and ends up disabled, which means your long-term disability, the government's going to pay for it one way or another is where I'm trying to go. They're either going to pay for it on the long-term disability side or they're going to pay for it on telemedicine. And if someone, and I'm not smart enough to do this, if someone could do the financial part on that, I guarantee you the way it's set up now, they're paying more out of pocket under the different departments than they are proactively doing telemedicine. I just don't know how to pull that together, if that makes sense.
Yeah, no, we have some of those cost studies that you know, Jason Goldwater and team have done, and you're right. I mean, it does show in probably most instances, Christa, I would say that, I mean, there are a couple unique circumstances where it actually doesn't show the cost savings, but yeah, you're absolutely right. That, I mean, I think it's very short-sighted of the CBO to not give that additional weight to the sort of future impacts of not providing telehealth care, because going without care is, you know, has been shown that the exacerbation of existing symptoms coupled with, you know, potential disabilities is much more costly than it would be to pay someone $50 to do a telehealth visit, right? So it's a great point. But I think as you see here, you know, from these examples, it is important as we think about advocacy and what's going to actually push people to act in a certain way. You know, the monetary aspects of it are probably not that impactful, right? If you're a member of Congress right now and you hear, okay, well, all the telehealth providers got paid, like, we're going to make sure they get paid at the end of the day, it doesn't really tell the full story, right? Because there's so much more to it. And I'm sure you guys lost patients. Patients went without care. You lost revenue. Michelle has a client who's selling their business because they can't make ends meet with this stuff happening. And it's just going to happen again in a month and a half, right? And I don't know if it's going to be a week, a month, 2 months, 10 months. We just don't know, right? And even on the Democratic side, there were calls to not end the shutdown, very, very loud calls. So it's very possible it could go longer in the future. So I think it's very important as we think about individual advocacy at the member level to be letting them know of those real world consequences that kind of come from the things that they're doing or not doing.
There's also a comment from Mark Noble in the chat, and if you want to jump in. It's obvious to me that we need to divorce telehealth policy from the budgeting cycles. We've been told in the past that the whole point of permanency was economic uncertainty for CMS. We were planning to gather the data that shows telehealth does not create higher overall government spend due to overutilization or ineffective use that results in duplicative services. Where are we in putting that data in front of CMS? And if you want to jump in, Mark, feel free to as well.
Thank you, Lydia. Yeah, wanting to pivot the conversation from what we know, which is, there's going to be continued uncertainty as long as we're tied to budgeting cycles and the impacts that has, to what are some strategies that we can implement in order to push the urgency on permanency with our representatives. And, the one thought is, the conversation from the past and the C, I know that we mentioned Goldwater had done some cost analysis studies and such. I don't know if that was the information that the CBO was looking for in order to be able to put the right documentation in front of our legislators. But that seems to be one path. The other that I would throw out there would be a public campaign. Given that, real people were impacted with this last government shutdown, and we do have these hidden stories about the impact to care and that sort of thing. And we are, necessarily having to put information in front of patients saying, hey, there's a possibility that we're not going to get reimbursed for the services that are being rendered as a result of, the failure of government to have policy in place. Maybe there's an opportunity to heighten awareness down to the patient level so that we end up with a groundswell of people demanding from their representatives that they get this done.
I think that data is also aged now. Oh, sorry. I think that data is also aged now and not as relevant. And I know you guys had a secondary piece of work that was being done, and I'm certainly hearing that from the people that I'm talking about, that information needs to be refreshed.
Yeah, and I think also on just on the CBO piece, we've highlighted this, I think, either last week or the week before. Our colleagues at Inside Health Policy recently put out a report that CBO recently did a recent analysis of, I guess, a recent scoring of telehealth through CMS, and that this time around they accounted for specific ACO flexibilities that were included in 2018. And that as a result of those ACO telehealth flexibilities, that these CBO score for telehealth had gone down. We don't know what the specific number of that was or to what degree that change was, but at least from what we've seen from the reporting at Inside Health Policy is that there is some movement on that. I think also at our last summit this past summer, we were fortunate to be joined by a representative from the Congressional Budget Office. Her name was Asha Savas, who does a lot of the Medicare scoring. And she was able to talk a little bit about what CBO was thinking in terms of how it's approaching telehealth. And one of the big things that they talked about was that they need more research connecting the ability for telehealth, something that we all know intuitively, that telehealth allows for the earlier detection and treatment of diseases before they're escalated to more costly modalities of care. But that CBO needs more evidence directly linking that so that they can include that in their actual score for telehealth. And that at the moment that they are unable to actually do so and account for that, which at least from our perspective, would make a very serious difference in how telehealth is scored by CBO. But that's also just one thing that they are thinking as they're going through their scoring of telehealth as well.
I guess what I'm wondering, Lydia, to Mark's earlier point, what is the vehicle, right? I mean, we have each of these sort of continuing appropriations budget cycles where, we had the COVID-19 waivers, flexibilities that were introduced at the very beginning of the public health emergency. Obviously, that expired in 2023, if I do my math correctly. And since then, we've sort of pushed it with all these continuing appropriations bills. The fix is obviously just changing a couple of words in the Social Security Act, so it's not difficult from sort of a technical standpoint. Joe, do you have something to laugh at?
It's not hard to change words. It is hard to change minds.
That's very astute. I like that. From a technical standpoint, the law is written that we want to have written in the future, right? But what would be a way to sort of break that cycle? I think the problem that I'm seeing right now is that, especially when it comes to the various parties and how they align or don't align, is there so much infighting and lack of collaboration at this point that any real permanent bipartisan supported legislation it isn't ready to come out right now, right? I mean, I think that's sort of the big issue. If you think about the Republican healthcare assessment, even just yesterday, right? They were saying, hey, we need to have innovation. They had a 10-point plan, which basically had HSA and then innovation, right? And it's just it was so high level and so meaningless as to be a joke, right? And you just worry that there's the real potential that the Obamacare premium tax subsidies are going to expire at the end of the year, and so is there anyone really that's going to be able to deliver realistic bipartisan legislation that is good and effective in any kind of near-term solution? I mean, I'm throwing that out there. I don't know if it's a yes or no, but I don't know if there's thoughts on that, or Lydia, if you have thoughts on that. Yep, go ahead.
This is a little outside my wheelhouse, but Mark's comment kind of got me thinking from the patient perspective, which I think there's definitely a lack of understanding from patients about all of this stuff. I mean, in general, but I do know from previous experience in terms of our strategy as it relates to the uncertainty is to, whether we shift more to concierge telehealth, which would eliminate a lot of patient access to services, because it would be cash pay. And it would be only those patients who could afford. And I would think that if you could engage patients in areas, perhaps more rural areas or areas where access is already an issue, could that influence their representatives of those rural areas? Again, outside my wheelhouse, but I really do think the idea of patient engagement, I mean, you joke patients as a collective are stupid, but individual people are smart. And I think that there's opportunity for, sorry, I mean, that's my thought of the general public as well. But I think there is opportunity for targeted education on the payment, whether they get billed, their insurance, that's less meaningful, but whether they are actually able to have a telehealth provider, I think speaks a little bit more strongly to the patient's desires. But anyway, my 2 cents.
Mm-hmm. That's a great point. Nora?
So many thoughts. Let me see if I can organize them. First of all, the patient voices have almost always been missing in this conversation because it's really difficult to get a grip on them. That being said, NAMI, AARP, we have some natural allies here that I know CTeL already has those relationships that we should really be leaning into, because those are very powerful. AARP in particular, I would not mess with them. And I know that they are pro telehealth.
They're very powerful from an advocacy perspective. So it might be having to go disease specific a little bit to try to loop in the American Heart Association, because I know they care about this. They're here, right? But they're a member. Like getting those people to be the spokespeople rather than the industry might be a thing that could be done a little more effectively than I think we do it. The other thought I had, though, I want to go back to Lydia's layout about the rumors of the change in the CBO score. This administration has launched a whole bunch of effort on the accountable care organizations. They want it tighter, they want it more market focused, they want it faster, they want all these things. Those people are also organized. And if you take telehealth away from them as a tool, that's going to hit them on downside risk. So if it's true that there's some subtle changes to the scoring because of the ACOs, I know Florida has an ACO association. My state is starting an ACO association. That might be another natural sort of partner that we could. CTeL is so good at building coalitions and bringing people to the table that are impacted by this stuff. I just think the ACOs might be a way to get at this whole, how do we decouple it from the budget cycle? Because of the pressures the Trump administration is bringing to bear on the ACOs. Now, I would not want to be an ACO right now. Let me be very clear. I would not necessarily want to be in that boat, but I think we have to be like hyper opportunistic.
They would naturally be advocates.
They would naturally be advocates, because if you take it away from them, you're creating all this pressure on them on the downside, and then on top of that, you're taking away a tool. Maybe that's a conversation that we could have.
If I could sorry. I was going to say, we have multiple ACOs in many states. We're a high performing MSSP organization. And when I mentioned before, our strategy to shift to concierge was a direct result of our fear of the downside risk that would happen, not only in the short term, but in the long term, as these patients don't seek care, aren't able to get their annual wellness visit. Well, we miss that metric. We're not getting, them in for various screenings. They miss that metric. And just the overall, once you lose the patient connection, especially if it's a rural patient or someone that's connecting mostly through telemedicine, very, very, very hard to get them into the office to meet those measures. So you're absolutely correct. And I think that's a great idea.
Can I ask, how does that concierge telehealth service work then? Like, the patients aren't paying for it.
No, it's, it just takes those patients who are going to be higher risk and less likely to be, I hate the word compliant with measures, kind of out of our pool, right? Because they're no longer going to be attributed to our physicians.
Okay.
We won't get the negative impact on our measures for them failing to have their annual wellness visit, for them failing to meet various A1C metrics or things like that, because they're not being monitored and cared for. And so that's why it was like, okay, it was partially about revenue stream, but it was also like, we can't count on that, and it could have a potential negative impact on us. So therefore, let's focus on using virtual care for women's health, for weight loss, for, all these other things that seem to be more in the retail brand of healthcare.
So one of the things that CTeL identified in one of our leadership calls is that there are so many organizations that are advocating for large companies and vendor service providers, but there's no one really in the digital health space that is collectively advocating for the patient position. And so CTeL at its core has always advocated for good quality medicine because it would advance the care of those patients. And then ultimately hospitals and health systems, would not have a rise, an unnecessary increase in emergency room visits by patients that are not being seen properly in a virtual manner. This kind of all goes back to our roots, where we in 2026, and Lydia and I are working on this document for our goals are for 2026 is we want to be more patient focused. And what that looks like is bringing in Heart Association and ARP, who are already very much engaged with CTeL. But I'd like for you to think of that, because these are the organizations that are going to be very well equipped with their government relations arms to be able to push telehealth. It's going to be less corporations and more of these patient advocacy groups.
Well, and can I add, and I think I may have said this the last time we were all together, so I apologize if I'm repeating yourself. We've got to put a MAHA spin on it, at least for now. And I'm not, you kind of have to check where the wind is blowing, right? So some of the things you were just describing, wellness, health, dietitians, all of those pieces are at risk if this infrastructure goes away, and it makes it harder to meet those MAHA goals. So it's annoying to have to shift every 4 years, but that's the system that we live in. And being in a red state, I'm already watching that happening, that old fights are being sort of repurposed and redesigned through a MAHA lens, and it's changing the winners and losers, which is very, very interesting to me. So I think the more that we can put the patient at the forefront and kind of tie it to how do we get to these core things, if you take this service away, then we've lost our ability to work that patient to a healthier place. Again, I really am going to be stuck for a couple of days probably on this uncoupling the policy from the budget cycle. But if we don't, we're just going to stay here for as long as the American people keep sending half Republicans, half Democrats to the Hill, which doesn't feel to me like it's going to go away in the foreseeable future.
Yeah, look, I mean, I think it's a fair point to bring up. The other piece of this, and it's probably not, what you want to hear, but we're still in our infancy, relatively speaking, right? I mean, in terms of this sort of new world of having Medicare telehealth coverage, it's been obviously on a sort of a temporary emergency basis. So, as I said, I think we will get there at some point, and it will be decoupled where it's just a permanent thing. It's just, it's going to take, more time than us sitting here think it should be taking. And that's just the nature of anything in Washington, D.C., unfortunately. So did you have something?
Yeah, just a couple comments in the virtual chat. Carol mentions that potential stroke is always covered by law, and that modifier G0 and stroke symptoms, even if not stroke, make the visit payable, ED or inpatient.
Thanks, Carol.
And then Sean notes that even if you change minds, it is now even more difficult to pass anything. You won't pass anything standalone. You'll need to build momentum and get something stuck to a broader bill. And then Mark notes telehealth is highlighted as being a critical component to transforming rural health in an economically sustainable way in the Rural Health Transformation Program. This is in direct contradiction to the argument for not making telehealth flexibilities permanent. And then from Carol again, shame they're not funding those wellness coach codes due to the policies in existence at this time, as well as a question for Jake. How did the mental health updates get in? I don't recall. Thanks. If you want to.
Oh, sure, Carol. It'll be $1,000 an hour. No, I'm just kidding. I think that was a standalone bill, though. The Matsui legislation. It was a separate. Bill, if I recall correctly. But I'll look into that, Carol. The other thing we just want to talk about, obviously, the major component that we're dealing with and thinking about right now is Medicare telehealth coverage. That's sort of the big one. But there's a bunch of other things in the federal landscape that are also in chaos. The other big one, I think, being teleprescribing. Right. So, there's something called the Drug Enforcement Administration, and they have a lot of rules about how people are supposed to prescribe controlled substances over the internet. And unfortunately, they have not been able to come up with a system that, would be fair, enable well-meaning providers to continue to prescribe controlled substances in the way they have, while preventing, diversion and misuse and abuse of those controlled substances. So we did, luckily, a few weeks ago, what we're thinking, we don't have the final, rule come out. We think that there's going to be another reprieve for probably another year till December 31, 2026 with the existing standards. Christa, is that confirmed in any way? Have you seen any? But it's pending still. Yeah, it's still pending. Okay. We're pretty. Yeah. I think everyone's pretty comfortable that the Ryan Height flexibilities will be extended for another year. But as we've seen, that's another major issue in Congress. It's another bipartisan issue. And because it doesn't have as much to do with budget cycling, to Mark's earlier point, Congress is sort of like on everyone's kind of saying the same thing, right? So I believe it was last year or 2 years ago. Was it last year? The Warner letter to DEA? Last year, yeah. So last year, when there was a concern that these flexibilities wouldn't be extended again or would be extended in a way that makes it impossible for telehealth providers to legitimately prescribe controlled substances, there was a bipartisan push to force the DEA to establish that special registration process that it had been promising to establish for the better part of a decade, basically. And so we're still back though at square one. We have another proposed rule that DEA has about the sort of registration for telehealth prescribers, as well as this likely rule for an extension of telehealth prescribing services through the next year. But again, in terms of permanent solutions, DEA appears to still be lacking. I think Congress is probably in more of a position to say, guys, please fix this. Shouldn't be this hard. But we will have to wait and see. I think they're obviously dealing with other issues. And so long as DEA keeps flexing this, I think that Congress is going to be okay with that.
There's a lot of politics with it too. So CTeL did a congressional briefing. It was open just to congressional staff and members of Congress on the House and Senate side in June. And CTeL completed research that has since been published in the Journal of Internal Medicine. And what the research found is that telehealth does not increase diversion of controlled substances. And we were able to come to that conclusion using a difference versus difference study, and that was conducted by our research partners at Charm Economics and CTeL's research fellows. The reason that research was really important is because literally last year at this time, DEA said we need data to show that telehealth is not going to unnecessarily increase diversion of controlled substances if we want permanency. So CTeL rushed and did that research. It is now published, which is fantastic because it starts the body of literature. We're calling on those that are around the table and in CTeL's membership that are in academic positions to help continue that research. But it at least qualms the fears of DEA that telehealth is going to unnecessarily increase diversion of control